suggestion we came up with is the government can raise revenues through betting. This would help to cover the UHC through NHIF. Also, there's another suggestion of earmarking, maybe through counties that have natural resources like Turkana. They can use what is gotten by the county governments, the revenue gotten, and it can be taken to the national government to cover for the same. Also, another suggestion was private healthcare to cater for government workers.
The issue was taking away private covers for government officers so that they all access public health, NHIF.
Reduce the cost of accessing services such as water. This would give room for people to spend more in health. And then the other one was subsidization of healthcare services.
One of the main debates that we had here, a heated debate, was whether earmarking is a good idea or not a good idea in terms of mobilizing resources for universal health coverage. So earmarking is a situation where taxes are collected and set aside for a specific purpose, as opposed to being left, flexible to be distributed to whatever needs in health and out of health. So one of the ways that was suggested to mobilize resources is to improve efficiencies, to reduce the wastage that happens within the health sector. And the observation that was made, which I completely agree, is that the poor are the ones that bear the greatest brand of inefficiency or corruption. And so when we tighten these loopholes and when we improve efficiencies, then we are actually mobilizing resources in an equitable way. Thanks.
Group 2, we consider the current CRA formula that is based on different variables. We have the issue of population, we have land area, we have equal share, we have issues of poverty, we have development factor and fiscal discipline. Then we asked ourselves, okay, among all this, is there a better method of distribution? We arrived at, okay, it was discussed that poverty and population are interlinked in the distribution of resources. We cannot distribute resources if we don't without considering the issue of how many people are poor at the poverty levels and what's the general population. Then another one was another issue that came in was the issue of whereby we can improve on this 70-30 rule, because counties want to hire more staff, but there's that 70-30 rule, 70 recurrent, 30 development. How best can we address this 70-30 rule?
Then we also added a few others, and we said that it's good to be able to define the function and ensure that resources then follow the function. I think earlier the CRA had tried to define the function of health and cost it, and there are still huge disparities between what is allocated and what is supposed to be allocated. So we need to keep moving closer to the reality as opposed to living far away from reality. Then we need to be very realistic in the criteria that we set. And here we cited, for example, the issue of Meru and Nakuru, being given the same amount of resources, but serving a totally different population. Then we are also proposing that population needs to be given a higher weight in the criteria. We were also proposing that we need to be able to reduce duplication between the national government and the county government, so that the amount saved can then be reallocated to some of these functions. We then also said that we need to improve accountability. We need to use evidence in the transfer of funds. We need to have more information given as we transfer the funds. For example, now under UHC, we need to define the benefit package and then allocate resources as per the benefit package, or progressively move towards getting to the benefit package. But at least we make the right steps to fund in the benefit package, because then that will take us closer to UHC.
The first issue that should be considered is data for easy rationalization. It will enhance this for easy allocation. During this process, we involve the people, the community involvement, and also the education. And for this process, for the fair process of equal distribution to be in order, there should be ethical bodies issues where they ensure that everything that is given to each counties and the sub-counties, they make sure that they reach there and they are done. And also we've looked about the roads and the infrastructure, because maybe you are locating to a certain sub-county or county to maybe hospital, they need a hospital there to be built, but you have to look first. Is this place, is the infrastructure, maybe is it safe? So you see, the money that they are going to be allocated will be different to that hospital way, they just near the highway, the road is just already there. So those are the things that we have to consider for the best equal resource distribution in terms of health.
The prioritization of the issues at the county level. If you look at the budgets at the county level, assume, for example, in Nairobi County it has 8 billion. If you look at the 8 billion, where it's going, you realize, for example, health with a workforce of like 3,000 people, it's getting 3 billion. A department like early childhood with a workforce of 200 staff is getting 1 billion. Is that equitable? If we want to achieve UHC, we have to focus on the primary health care. In a county whereby you are putting up, for example, a 4 billion referral facility, do you need a 4 billion referral facility when the primary health facilities don't have the Panadols? Because the 4 billion can provide healthcare free of charge for the entire county, but our leaders want the mega projects. And then 3, I've been wondering, do you need the 47 referral facilities in each county? Even in counties whereby the distance from one referral facility to the other is less than 10 kilometers. Do you need like the 2 referral facilities? Then second last, the oversight role of the MCAs, the various health committees at the assembly level. You know, the position are just given. You just decide that we want to share kila mtu position, then we assign 1, 2, 3, 4, 5 go to this committee. But if you ask the MCA, if you go out for an outreach to do oversight in a facility, what exactly are you going to oversight? They don't know. So that's an area we can build on. And finally, it's about leadership and management, a very key component of UHC. We are to achieve that.
Our group came up with 4 points, and the first point was the national government should distribute the health personnel and specialists in different counties. You find like maybe county A has so many specialists, and county D doesn't have, maybe have 2 or 3. So we can ask county A to, we can share the specialists there in different counties. And then the next point, we saw that we need transparency between county government, national government, and the private sectors. We need to know who does what, so that we should avoid the repetition and the backlashing. Then the third point was we identify the primary issue in the different counties that you have. You find like maybe in Turkana, there are more painkillers, and in Turkana they don't need painkillers. Maybe they need cancer medicine. So what are we supposed to do? Like we're supposed to focus more on the cancer medicine rather than giving the painkillers, right? And then the last point was to have meaningful public participation on the health budget.
And I agree with your recommendations. I mean, there are 2 things that come out of it. One is that listening to you, giving suggestions about considerations that should be used, reminds me of the fact that these allocation, it's a priority setting or a resource allocation process, and it needs to have an explicit criteria. Okay? So when we talk about how do you allocate resources across across counties? How do you allocate inputs? You have to ask yourself, what considerations are we going to make? And you've given examples. You don't want to give an excess of an input in one place and it's not required, and less input in another place when it's required. So you need data to tell you what are the needs, for example, and so on and so forth. So we need these criteria to be explicit, they need to be known, and they need to be used. And secondly, and most importantly, is you talked about community participation, which to me means essentially, number one, accountability, making sure that the system is accountable to the final person who is the citizen in the streets and so on. And secondly, it's about making sure that community voice is considered in decision making, because we are making decisions that will affect citizens. So we cannot make decisions that will affect citizens and then we do not incorporate their values and their voice. So priority setting processes have to incorporate very explicit criteria, and they have to make sure that they are grounded on community voice. And this is part of what we are trying to do as a health benefits advisory panel, which is to come up with very explicit criteria for making decisions about what services to cover and what services not to cover, and making sure we have community participation, we have community voice in the process.
Came up with 3 points. Number one being, we should set up follow-up committees on policies to ensure that funds follow functions. And these committees should not only be based at the national level, we should even have committees at the grassroots, at the village level. Number two, we should include everyone, public participation, not only in Nairobi, even at the grassroots, the mama mbogas. We should tell them that we have a public participation on this and this. Then number three, we should enlighten people on universal health coverage, whereby when we are advertising these things, we should not just put them on Twitter or Facebook. We even advertise them on our local radios and such a thing, and even involve the provincial admins like the chiefs. Yeah, and even involve those people who call themselves voluntary workers to preach the same message.
One, communities and civil society organizations, or CBOs, should be involved. That is, their participation in monitoring and evaluation of health services is very key to answer number 5. Information sharing, and with this we mean the information, including budget making processes and such alikes, the public should be allowed to access such information to have meaningful participation. And then an oversight body to oversee county governments and work as well as, county governments work as well as the county assemblies. Our politicians, our leaders should move away from the party politics. We need to have independent minds. We need to separate work from politics so that we achieve this big agenda. And then the establishment of health data centers, which would look at the drugs, at the supply of drugs at the health facilities, and all related services that come forth with that. And then lastly, awareness creation. That is, the Auditor General's office should work closely with communities. The communities should be involved in the work that the Auditor General office is doing, so that we achieve the successes of that office.
I would like to say that for accountability purposes, so that at least accountability can be seen, I think the following points as per my group has laid down that we should involve the community, at least community participation, even the mama mbogas from the grassroots level, not only from the national level. Another thing is that they should work all along with community health volunteers. If they work with community health volunteers, they will have this good, at least, report to implement anything they want to implement on the ground. And because it has come from the community level, it will be able to favor even the poorest person. Another thing is that they should work along with the chiefs, because you also know the chiefs, they reach the community easily when implementing any of these things.
We have students from the university, colleges who are 18, and most of these are not covered by their parents. And for me, it's a concern, because as much as I would want to pay that 500 shillings, and I have like 3 or 4 children in colleges, when it comes to 2,000 per month for the NHIF, it becomes very, very difficult. And no one in NHIF answers that. So there are very, very many small things. And for me, I wish this would be a longer period, and then we'd have somebody from NHIF to answer all these many concerns, things that are on their website that are not addressed. So Mwananchi actually suffers a lot. And so because of this suffering, we say, wacha nikae, and then when you get sick now, yes.
If you go to a facility, you have, what are they called, suggestion boxes and so on. The NHIF has a number that you can call. Budgeting process now has a public participation process. So the problem is not whether they exist or not. The problem is whether they are effective. They've always been there, and we keep coming up with more and more of them. The question is, are they effective? Are they actually being used to hold the system accountable? Are the people who are participating empowered to make decisions? So those are the questions that we need to begin to ask ourselves. And in work that we have done has shown that actually when the further down you go, once you start getting to primary healthcare facilities, once you start getting to community health systems, then service delivery begins to become more equitable. But as you come up the system, when you start focusing on hospitals and level 5 and level 6, then you begin to see resources being allocated to the rich and the poor being left behind. So the simple message is we must prioritize and invest, not just talk about it, and invest in community health systems. So that is an explicit goal of universal health coverage.